Today, we are going to move on to the post-segment surgery. We'll look at how to optimize a vitreoretinal surgery, and then focus on the preoperative preparations. This will be the overview of the presentation. I will try to summarize it all in these 8 preoperative issues. Let us start with something very subjective, that is dealing with patients' expectations. Or in our culture, I would say it's more of dealing with their family's expectations, which is just as equally important. These are our common scenarios in the clinic. There is a very high level of visual threshold among our patients. Which means, our definition of good vision may not be the same as what patient perceives as fairly good vision. For example, good vision for us is 6/9 or better. Whereas patients may perceive 6/24 as an acceptable good vision. That is probably the reason why most of our patients present themselves at a very later stage of the disease. Occasionally, there will be some inconsistency in the history. They tend to forget the discussions we had prior to the surgery and keep asking for perfect recovery of vision. So, be patient. Keep repeating the same advice over a few sessions of consultation. When it comes to discussion about the outcome of surgery, it is important to highlight the quality of vision involved. This can be either improvement of acuity or improvement of visual field. Therefore, in some chronic cases, you might not expect improvement of visual acuity but probably improvement in the visual field for navigation purposes. This kind of expectation has to be made clear to the patient and family prior to surgery. One important rule is to never push away your patient. We now know that vitrectomy carries a slightly higher risk compared to cataract surgery. Therefore, it is important to convince the patient on the benefit of surgery rather than dwelling too much on the risk, as it may scare the patient completely. The easiest way to win over the discussion is by comparing the risk of blindness from not having surgery and the risk of blindness from surgery itself. For example, for retinal detachment, no surgery would mean a 10/10 chance of blindness. However, if surgery is done, chances of going blind reduces to almost only 10%. In other words, patients may still go blind from the failure of surgery but at a significantly lower percentage. Most patients will agree for the surgery once you tell them this. Personally, I find it easier to deal with the expectations and allow important family members to be part of the discussion. So again, be patient. Repeat the same story for at least the first couple of visits until they accept the condition. There is a long list of important details in history, and the most commonly missed are the social and financial background. This especially applies to young patients. We know retinal patients tend to stay with us for a couple of months. Happy patients lead to happy surgeons. Always try to put yourself in patients' shoes. Are they the sole breadwinner of the household? Is the employer supportive? How many days of MC is allowed? Does he need any supportive documents? And are there any supportive family members during the recovery period? Now let us look at the importance of detailed ocular drawings. Always try to correlate the patient's story with ocular findings. We can predict visual outcome for RRD cases, for example. Acute RD may lead to the improvement of vision. Chronic MAC-off RD is predicted to result in a lesser improvement of acuity, but a better visual field, either centrally or peripherally. Acute on chronic may behave similarly as chronic detachment, with high chances of PVR and failure. When dealing with diabetic cases, don't forget to look at the blood vessel in diabetic patients. Chances of diabetic patients to have a reduction of vision post-surgery ranges from 5 to 20%, depending on the status of ocular perfusion. Based on our study, less than 1/3 of patients experience a one-line reduction of Snellen acuity. However, a majority will have improvement in the visual field. A detailed examination is also important to predict the complexity of surgery. For example, a patient was presented with a sudden onset of reduced vision post-cataract surgery. She was diagnosed with worsening of TRD post-cataract surgery. As you can see, there is circumferential RD. A careful examination of the fundus reveals a highly elevated retina, with some corrugation. Its distribution does not correlate with the Linkoff's rule. Upon further detailed examination, the presence of subretinal band is revealed. Basically, this tells us that this is a combined TRD or RRD and not just TRD. The case has to be done earlier, because the progression can be fast. Surgery can be prolonged, because occasionally, There may be a need to remove the band to flatten the retina. Another example is the subretinal band, which were not apparent during clinical examination due to the thick pre-retinal fibrosis. Once fibrosis is removed, we can see the subretinal band much clearly. Remember, pre-retinal fibrosis secondary to TRD usually sits on top of the large vessels, and as we can see in this case, whitening or fibrosis is away from the large vessel and is subretinally located. In summary, always suspect combined TRD and RRD. If the retinal elevation is high and disproportionate to the amount of traction, then there is a presence of corrugation and subretinal fibrosis. The tear is not visible in a big proportion of patients, small and contracted within the fibrosis. Therefore, you will be looking for the indirect sign of rhegmatogenous component in TRD. Then again, the patient should be listed for early surgery. Occasionally, in high myope, they will have some peripheral degeneration. That is, the lattice will be easily torn off during the PVD induction. With the presence of lattice, PVD induction has to be done in a gentler manner and the complete trimming of vitreous is mandatory intraoperatively. And what about the timing of the surgery? For example, acute rhegmatogenous detachment requires early surgery. Macular on cases for early operation. Young patient recover faster and better, therefore we suggest early operation. What about vitreous hemorrhage for various causes? Traditionally, in diabetic, we were allowed to wait for 3 months, but things has changed with improvement of surgery. We do suggest early vitrectomy, especially if firstly, the laser was never completed, the vision was potentially good prior to bleeding, or the vision is equally bad in the other eye. What about vitreous hemorrhage related to ARMD or IPCV? In all VH cases, when you do a B scan, don't forget to orientate the probe towards temporal in which you are looking at the macula. Once you detect the optic disc on the scan, look above it. That will be the location of the macula. If you find some amount of elevation in an old patient, suspect this could be an IPCV or ARMD related bleed. How long do we wait? Remember, if there is fresh submacular hemorrhage, we will always advocate pneumatic displacement of the blood within 2 weeks. The same goes for acute VH secondary to IPCV. If history suggests this is something new, then early PPV may save the vision. This photo here shows the before and after blood displacement. Other conditions you may want to list early are a retrogal bleed, which may take some time to resolve, and retinal tear or detachment. Now let's look at the laterality of the eye. This situation happens mainly if both eyes are equally bad. Remember, the principle is not only to save the eye, but also to get the patient to be up on its foot as early as possible. Remember general rule of vitrectomy as stated here. For example, if patient presented with complaint of poor vision in one eye for a month, we found that they also have a significant cataract in the contralateral eye. In this case, cataract surgery in the right eye should be done first. This gets immediate good vision for the patient. And then, list up the left eye as soon as possible, within a week or 2. Another example is of a patient presented with bilateral TRD, better vision in one eye. If we are going to choose the better potential eye, which is the right eye, remember, the left eye is not enough for safe navigation, as the patient has since been relying on the right eye. In this situation, we can still go for the better eye, which is the right eye. However, consider silicone oil as the endotamponade rather than gas. The reason in such case is because silicone oil gives fairly better vision compared to gas. This will allow early planning of vitrectomy of the other eye. Imagine if we decided to put in gas in the right eye, giving the patient home vision for both eyes. Patient will be completely dependent on their family members, and possibly delaying the surgery of the other eye at the same time. Next, remember the relative indication of oil. When we operate on a good single eye, it will lead to a potentially poor posture. In Malaysia, I find festive season is not a good time to do vitrectomy. It needs a strong, motivated patient to keep still during these festive season. Those who are too busy to posture will experience active PDR or TRD with high risk of rebleeding in those who need to fly. Let's look at the systemic escalation preoperatively. Apart from controlling DM and HPT, proper systems workup will assist the decision for the need of general anesthesia. In particular, Be careful with anticoagulant. Aspirin is fine for most surgeons, but other than aspirin, majority prefer either stopping or switching to short-acting anticoagulant. Another issue to consider is to be careful when switching warfarin to heparin. I remember a few cases of IHD, pulmonary embolism and bowel ischemia during the switching period. In our community, it is sometimes difficult to get the sugar to be at the optimum level. But at least stabilize it before surgery and avoid fluctuations as much as we can. For example, this patient did well post-vitrectomy for TRD with a 6/18 vision. However, their sugar were fluctuating very badly. 4 months post-operation, she developed neovascular glaucoma and eventually NPL and was resistant to treatment. Another complication would be suprachoroidal hemorrhage, which are mainly found in old patients, underlying hypertension, high myopes and post-silicone oil removal. Now let's look at the choices of anesthesia. 90% of VR cases can be done under LA, but in some cases, would also consider GA. These are among the common causes of GA. Feeling claustrophobic, stiff neck, anxious, head titubation, prolonged surgery and at a very young age. And remember the risk of GA, since we deal with a lot of old patients, including the risk of prolonged extubation and heart attack. Yes, we have other options too. Luckily 90% of our cases are done under regional anesthesia. But which one is the best and concurrently safest? I have long lived with sub-10 in LA and move away from retrobulbar or parabulbar injection. Since then, I sleep better at night before and after vitrectomy. My personal experience with iatrogenic retrobulbar hemorrhage was not extremely good. These are the cases which I encountered during my training. I have to admit it was my patient, even though I was not then injecting it. But surgeons have to endure the complications. 4 patients recover well in terms of vision, 1 case ended up NPL. It was a case with advanced TRD with probably small residual of visual field, and it was the only eye. Another case developed convulsion immediately after the injection, preparing for a simple oil removal procedure. We can't blame the one who inject, as it is known to be a blind procedure. Those 2 cases really taught me well and has changed my preference for anesthesia since then. All my cases will be done under subtenant anesthesia. Next up, the adjuvants. That is, anti-VEGF and recombinant TPA. We are lucky to have a few adjuvants to be used prior to vitrectomy. Namely, anti-VEGF, which is used in diabetic-related VH, diabetic-related RRD and TRD-RRD, and rubeosis. The benefits of preoperative anti-VEGF are reduced intraoperative bleeding, reduced timing of surgery and a shortened period of post-operative VH. Instead of post-segment anti-VEGF, we can also inject anti-VEGF in the anterior chamber. This is a case of a young lady, the only eye, presented with 1-month history poor vision. She has underlying avascular retina secondary to ROP, the scan showed retinal detachment. She has this huge retinal vessel running across the pupil, in front of the lens. Since this was the only eye, we had no choice but to agree for the surgery. We injected intracameral anti-VEGF 5 days prior to surgery. The vessels were almost completely gone by the time we are going for vitrectomy. But always remember, anti-VEGF may cause sudden contraction of pre-existing fibrosis. So, make sure the medical condition is optimized prior to surgery before you decide to inject in TRD or PVR cases. Recombinant TPA, another magic drug. We can use this for anterior segment fibrosis preparing for surgery. This case was a case of FB-related endophthalmitis. Complete PPV with removal of foreign body is needed. Hence, a good view is mandatory. Prior to RTPA injection, it was difficult to view the fundus DT, the fine fibrin and AC reaction. After few hours of RTPA, everything settled down inferiorly. The view was much better and surgery was performed on the next day. And last but not least, the need for posturing preoperatively. We always advocate posturing post-operatively. However, in some fresh cases of RD, preoperative posturing works well too. We commonly do it for MAC on RD to preserve the macula, but we can also do it for MAC off RD. This is an example of a young patient with fresh RD and a vision of home. While waiting for surgery the next day, we advocate posturing towards the tear site. In this case, right lateral. Within 24 hours, detachment becomes less bullies and subjective vision was better. Posturing pre-op allows to reduce the complexity of surgery and keeps the macula attached in case of MAC on RD.